Hello. Hello. Are you able to hear? Raise your hand.
So,
Okay, thank you. So we are going to talk about brainstem stroke syndromes. And before we start, I'll just say that last class there is a recap, and that recap is about anterior circulation stroke syndromes. We just briefly tell you that the blood supply, which we have studied earlier, and we're going to do it again. And the brain stem is basically supplied by the basilar artery and the superior cerebellar artery, posterior inferior cerebellar artery. The vertebral arteries both join to form the basilar artery, and it divides into posterior cerebellar artery, and it has a lot of branches which I will show you again, and these will supply the brain stem. This is called posterior circulation. And this you can see the vertebral artery ascending through the foramina of cervical vertebrae, and both the vertebral arteries join to form the basilar artery, and then subsequently the circle of Willis, and these various branches of basilar artery will supply the brainstem. So in the last class we talked about the big picture of the brain, the arousal, awareness, frontal syndromes. We discussed about the memory, language, vision, and also spatial attentions, motor systems, apraxias, and somatosensory processing, etc. And these are the things which we discussed. Now look at the small branches that are going to happen in the posterior circulation, the small artery branches. These are the perforator branches of the posterior cerebral artery, and you can see these are all the areas that are supplied and by the later bilateral thalamic area in the superior part, and the thalamic perforators can come from a stem. It can be one from one stem, then it is called artery of Percheron. And now we'll come to the, I think most of you have joined. Now we'll start the brain stem. The brain stem starts from midbrain, the pons, and the medulla. And the medulla, and so this is the area of the midbrain. And you can see that the midbrain has got superior colliculus, the inferior colliculus, that's the midbrain part, and the superior cerebellar peduncle coming from cerebellum, middle cerebellar peduncle, and the inferior cerebellar peduncle, and the facial colliculus and the medulla and pons. This is a pontine area. So
sir,
midbrain,
figures, we can't see the figures.
you can't see the figure, is it?
Are
Oh,
there figures? Only one picture is there with dendrites and all.
I'm not seeing the figures.
Then,
Uh-huh.
yes, no, sir.
Yeah, we'll do it again.
Yes, sir,
Right,
please.
right, okay. Are you able to see anything now?
No, sir. Only
Okay.
cell and dendrites they are seeing.
Now are you seeing anything? No.
No, sir, no. Only first slide is there, that is picture of
Brainstem.
that cell. Brainstem, yes, sir.
Oh, okay.
Nothing
Uh,
after that
th- this is
came.
not seen. This is not seen. No.
No,
Right.
sir, no, sir.
Okay. And then I think we'll have to start here and here, and I'm going to start here and say the recap. Then I have to close this. Okay. 1 second. I'll do it. And I'll do it. This thing will close. Right. Okay. This call. Screening a stop. Okay. Right. And recording fast. I will start the sharing.
Nitya?
Yeah. Are you able to see now? Is it visible?
Yes, sir.
Yeah.
Yes, sir, we can see now.
Okay, good. So
Yeah.
the midbrain, pons, and medulla, three things you have to remember. If you remember midbrain, pons, and medulla, you also remember the ventral aspect and the dorsal aspect, medial and lateral aspects of this midbrain. And you can see the various parts, as I told already: superior colliculus, the inferior colliculus, the pons, and medulla. So these things are very clearly depicted here. So it's like a highway, the highway of there are so many tracks that are going and coming. So tracks are coming from the cerebrum to spinal cord, or cerebral cortex to, you see, cerebellum, and there are tracts that are traveling from one area of the brainstem to the other, like medial longitudinal fasciculus. And when these things are happening, there are cranial nuclei here and here and here. So, what these brainstem syndromes, because of the stroke, happens is this called crossed hemiplegia. One side you have a cranial nerve deficit, and the fibers have already crossed, so you will have hemiparesis on the other side. So it is impossible for a damage to spare any of the cranial nerve nuclei and involve only the long tracts. Though you may have ataxia, you may have hemiparesis, you may have misalignment of the eyes along with other cranial nerve palsies. So that's most important thing to learn. So this brainstem is home of the nuclei that project axons through cranial nerves 3 to 12. That means optic nerve is not there. This is the oculomotor nerve onwards till hypoglossal nerve. The transmission of information is between cortex and the spinal cord because long tracts are involved. Transmission of information also happens between cortex and cerebellum. Transmission of information between cranial nerves also happens, that is medial longitudinal fasciculus. Let's look at the 4-4-4 rule of the brainstem. If you look at that, there are 4 cranial nerves exclusively in the medulla, that is 9 to 12. So anything that happens, dysphagia, dysarthria, nasal regurgitation, dysphonia, if a patient presents, then you can think that these are the nerves that are likely to have been damaged. There are 4 cranial nerves primarily in the pons, that is cranial nerve 5, motor 6, 7 and 8. That is auditory nerve, facial nerve, and this is abducens nerve and the trigeminal nerve. There are 4 bumps in the midbrain. They are called colliculi. Superior colliculi right and left, inferior colliculi left and right. So the level of superior colliculus lives between the third nerve. At the level of the inferior colliculus lies the fourth nerve. So the colliculi are the part of the midbrain. So this anatomy should be remembered, and 4-4-4 rule to be applied, and crossed hemiplegia or ataxia has to be kept in mind. So localization in the vertical plane, that means in the direction like this, by the cranial nerve nuclei or cranial nerve axons that are affected, with the exception of the fourth cranial nerve, the lesion is ipsilateral to the cranial nerve deficit. That means if third nerve on the right side area is damaged, there will be right eye third nerve palsy and left hemiparesis, which is called Weber's syndrome. Exception is fourth cranial nerve. So fourth cranial nerve has got exceptions. It is the one cranial nerve that originates dorsally, and also it decussates at the origin itself. And so right fourth cranial nerve supplies left superior oblique muscle. So if you look at this, these are the sensory things, these are the motor things, and you can divide them into 3 regions: pons, medulla, cervical spinal cord. And you see, and you have as a 4-4-4 rule, you have to think the 4 cranial nerves of the medulla, 4 cranial nerves of the pons, and the 4 lumps of the midbrain. Remember, the distribution of the motor and sensory tracts also will help us in remembering the things. You can see that this doesn't require too much of explanation, because we are going to see more of these diagrams. So localization in the transverse plane by the long tracts that are affected. In the transverse plane, the long tracts that are affected, the corticospinal tract and medial lemniscus are ventral and medial. I'll show you a diagram. That means the ventral and medial. Ventral and medial. The spinothalamic tract, descending first order sympathetic neurons, and the cerebellar peduncles are dorsal and lateral. With the exception of the caudal medulla for proprioception and vibration, the lesion will be contralateral to the hemiparesis or hemisensory deficit. That is what is called crossed hemiplegia. Crossed hemiplegia is characteristic of brainstem lesions. So if you look at this anatomy is very important, and this is easy to understand if the way I tell you. If you remember, this is a ventral side is always motor, corticospinal tracts, and this is the central line, and you get median longitudinal fasciculus, and laterally is the spinothalamic tracts, right? Dorsally you have the special sensors. This is the eighth nerve nucleus, this is the fifth nerve nucleus, and also the visceral or the V1, the fifth nerve nucleus. And you see this is the autonomic nerve, the the fibers of autonomic nervous system, sympathetic nervous system, they are also there. And you see the central is a reticular formation. The brainstem strokes may be associated with loss of consciousness if there is involvement of reticular activating system. So you now you understand the anatomy, because we have to remember to localize by symptoms and by signs whether in brainstem the affliction is on the ventral side or it's on the dorsal side by looking at the diagram. Okay, next. So the pure sensory cranial nerves, that is the sensory part of the trigeminal. Trigeminal is a mixed nerve, but the principal sensory nucleus which I showed you is here. So that is the somatic motor, mainly the cranial nerve 5 is here, the cranial nerve 8 is here. Okay, and these are dorsal and lateral in the brainstem. Motor cranial nerve involvement can be challenging to localize in the ventral. That's because what happens is the cranial nerve, the fibers have to cross like this and come out. I'll show you in another diagram. Most of the motor cranial nerve nuclei are dorsal and medial, but their axons travel ventrally to exit, except for the fourth cranial nerve, which supplies the superior oblique muscle. A fourth nerve lesion within the brainstem must be dorsal. Unless you can differentiate motor cranial nucleus lesion from the fascicular lesion. That means if there is a nucleus here, there is a fascicle here that will traverse through the subarachnoid space and exit to the foramina. So a damage can be at the nuclear level, at the fascicular level, or in the periphery also. You do not, because we cannot, like sensory nuclei, cannot depend mostly on the motor cranial nerve nuclei. In addition to that, these cranial nerves can be afflicted when they are in the subarachnoid space, and as suggested by multiple cranial nerve. So if you remember the diagram of the brainstem, so many tracts are going up and down, and the nerves are coming out, and this is the subarachnoid space. So only cranial nerve deficits not associated with any of the tract deficits, that is no ataxia, no hemiparesis, multiple cranial nerves, that will suggest it is as a subarachnoid space localization, except the internal internuclear ophthalmoplegia, which I will show you in the coming slides. So this is a wonderful diagram which you see was I trying to tell you. This is the motor nucleus of the 6. It will come like this, and these are the fibers that have to travel out, and this is the 5th nerve, 7th nerve nucleus that has to go out. So you see how the motor fibers have to travel through the brainstem parenchyma to exit. So this will lead to a bit of confusion in localization. So let's look at the midbrain first. The midbrain is now the picture reversed. You see, this is the aqueduct of the midbrain, and oculomotor nucleus is here, and also ascending trigeminal tract and medial lemniscus are here. Red nucleus is present here, substantia nigra is here, and crus cerebri are here. So that means this is a motor part, this is a ventral area, and this is the dorsal area. Anteromedial, this is anteromedial area, B is anterolateral area, C is lateral area, and D is dorsal area. So these are the various areas of the brainstem which we will be discussing. And affliction, see, you see crus cerebri, substantia nigra, red nucleus. So what are the main clinical features? Gait ataxia, limb ataxia, and sensory symptoms, dysarthria, third nerve palsy, and hemiparesis. So you remember that third nerve is in midbrain, and what characteristically we see is Weber's syndrome. So now see crus cerebri, substantia nigra, ascending trigeminal tract, medial lemniscus, and you see this is the MRI picture of the midbrain, and you see there is a damaged area here, right? So this area will afflict this part, and clinically patient will have a what we call lateral medullary syndrome. Similarly, if we go into the midbrain various areas, see these are all the various cuts of midbrain at various levels in the MRI, and this is the particularly the midbrain area, and this white is the abnormal infarcted area, and because of the blockage of the vessel in various parts of the midbrain and the small areas which you have seen already, and they are affected, and you can get oculomotor nerve palsy, hemiparesis, ataxia, and hemisensory changes depending on whether they are present in the ventral area or whether they are present in the dorsal area or whether they are present in the lateral area. And because the vascular lesions which you are able to see here, and these occlusions are there in small areas of the brain are infarcted and giving rise to various problems. Right. Now let's see a case and you'll understand better. A 50-year-old diabetic woman has sudden onset of right arm and leg weakness. Just remember, on examination, she has a right hemiparesis and right hyperreflexia. You examine her eye movements and find this is the eye movement. Are you able to find any difference between this eye and this eye? There is a droop here, and you look at this. So there is a right hemiparesis, and also there is a eye movement abnormality. Now you look at this eye, she is asked to look up, she is looking up. This eyeball is moving, but this eyeball is not moving at all. And you ask her to look down, the right eye is moving down, but the left eye is not at all moving, and the pupil is dilated. So here the eye movements are totally restricted on the left eye. So where is the most locally localization? The eye movements that are on the midbrain. That's of course it's true, it's in the midbrain. We learned that ventrally motor, dorsally you got sensory. So is it right dorsal midbrain problem, left midbrain problem, left ventral midbrain, or subarachnoid space? So these are the options which you have, and you can see the diagram once again, and this is a midbrain diagram, right? Because they got right hemiparesis, it has to be on the left ventral midbrain. Okay, and you see there are ventral midbrain, and the lady also has somewhat called the third nerve palsy, and third nerve has so many fascicles. It supplies inferior oblique, superior rectus, medial rectus, inferior rectus, also supplies pupils, also supplies lids. So this is the oculomotor complex that is coming, and this is the oculomotor nuclear complex, and this is the red nucleus, and this is a substantia nigra, and this is a crus cerebri. So you see this diagram, you remember from midbrain. Midbrain has these important aspects, and because brainstem stroke syndromes are dependent on your knowledge of brainstem anatomy, right? Suppose this individual has a anisocoria, that is pathological anisocoria is an efferent problem. You show some light into the eye, the light travels at the optic chiasma, it bifurcates, it goes into Edinger Westphal nucleus and supplies on both sides, but you see the efferent act. The efferent will come separately. The afferent for from one eye it is going to both eyes, mean the control, but when efferent is only, so efferent problem is always a motor problem. Whenever you have efferent problem, anisocoria manifests. So look at the pupil to light. Whereas sympathetic dysfunction, the pupil is constricted and it increases in the dark. So this is called the Horner's syndrome, sympathetic dysfunction, usually in the Horner's syndrome. Okay. Now this is what we have seen. This is the area that is affected in the this orientation is reversed here. That's why you are getting a bit confused. Okay, in the following four diagrams, identify the structures, and that will be very interesting. So you see, uh, what are these structures which you are seeing here? What are these structures? See, these diagrams, unless you practice, you will not master this. Okay, you have to master this. These diagrams, brainstem is learned by diagrams. So, what are these, and what are these structures? So, just remember what are the structures which I mentioned in this. What are the structures I mentioned? What is this? What is this? Is what? Okay, and this is what now? So there are four syndromes that are present on this. First is Weber's syndrome. Because of posterior cerebral artery perforators are supplying this, and what are the areas that are involved? This contralateral hemiparesis is due to cerebral peduncle. This is the motor area that is involved. Ipsilateral cranial nerve palsy. This is the nucleus of the cranial nerve 3, but what is affected is the fascicle is affected. Impaired ipsilateral pupillary reflex and dilated pupil. So this is Weber syndrome. Remember the diagram. You will have to no remember mentally, and then only you can really focus on this. And learning midbrain is a bit difficult. And second, first you have learned Weber syndrome, and now we are going to do Benedict syndrome. It is also same. The posterior cerebral artery perforators supply this area. Midbrain tegmentum is involved. Again, the cranial nerve 3 is also affected here. Sorry, and cranial nerve 3 also is affected. Are you able to follow, you people? Nigra are also affected. So contralaterally, you will have involuntary movements. Okay, right. Claude syndrome. Here again, tegmentum of midbrain and cranial nerve 3 as is involved. Ipsilaterally, that fascicle is involved. Contralateral hemiataxia and dysmetria due to involvement of dentatothalamic fibers in the superior cerebellar peduncle. So you have contralateral tremor, that is Claude syndrome. And so you learned about Weber's, Benedict's, Claude's, and Nathaniel syndrome is you have contralateral heavy ataxia because only fibers of dentatothalamic fibers, that is from the cerebellum, dentatorubro-thalamocortical tract fibers are involved. You will have contralateral ataxia. So you have learned four syndromes in the midbrain: Weber's, Benedict's, Claude, and Nathaniel. Now let's go to the pons. So this is the summary of these syndromes: ventral midbrain, Weber's; ventral midbrain and tegmentum, Benedict's; and midbrain tegmentum is Claude. What you have to remember is ipsilateral third nerve palsy, contralateral hemiparesis when cerebral peduncles are involved, contralateral ataxia and tremor when brachium conjunctivum and red nucleus are involved. If you see, this is the fiber that is coming from the cerebral cortex. You go to the pons, middle cerebral peduncle, it goes to the cerebellum. From there, it goes back, and any lesion here will cause contralateral ataxia. And that's what is depicted. Usually, ataxia means ipsilateral cerebellar involvement. In addition to that, contralateral ataxia can occur if there is any lesion in this circuit. This is cortico-pontocerebellar, and from here dentatorubro-thalamocortical circuit. So this circuit is, you should remember, and is going to help you a lot. So case 2. 50-year-old diabetic woman has sudden onset of right arm and leg weakness and double vision. So important is that eyes are involved in midbrain along with hemiparesis. On examination, she has a right hemiparesis and right hyperreflexia. She has bilateral ptosis, bilateral upgauge paresis, reduced left eye depression and adduction. That is adduction. Adduction of the eye is defective. And what is the likely localization? So now you see midbrain, whether it is right dorsal and ventral, left dorsal and ventral, only right ventral, only left ventral, right dorsal only, left dorsal mid, bilateral dorsal midbrain, bilateral ventral midbrain. So depending on the symptoms which we encounter and signs we see, we should be able to diagnose. And the question is, the mental picture of midbrain should be there. It is left dorsal and ventral midbrain. Ventral because they got hemiparesis, dorsal because the ocular abnormalities are also conveyed on that side. So you see, this is the oculomotor nucleus, and which you should know. There is a central nucleus which is supplying bilateral eyelids. This is the nucleus, central caudal nucleus, which supplies the levator palpebrae superioris. So there is bilateral ptosis. Ipsilateral medial rectus, inferior oblique, and inferior rectus are supplied by the nuclear complex on the in the midbrain. On the same side, they are supplying to the muscles. One thing that is surprising is the superior rectus is supplied by the contralateral nerve. This is coming from the opposite side. So eye muscles, there are 6 of them: superior inferior rectus, medial and lateral rectus, superior oblique and inferior oblique. So these 6 muscles you should remember, except the oblique, superior oblique by the trochlear nerve and lateral rectus by abducens nerve. All others are supplied by third cranial nerve, that is medial rectus, inferior rectus, inferior oblique and superior rectus. In this, inferior rectus, inferior oblique, medial rectus are supplied ipsilaterally from the same side, whereas superior rectus, that will come from opposite side. Like that, the fourth cranial nerve, as I said, is also decussates at the origin. The lateral rectus, the sixth cranial nerve, is again the ipsilateral. So in this case, the bilateral ptosis suggests that this part is also involved in this case. Case 3. 50-year-old diabetic woman has sudden onset of double vision. Now, her neurological examination is normal aside from anisocoria, which is worse in darkness. So, anisocoria is this one. That means the pupil is dilated, which is worse in the. So, is it a parasympathetic involvement? Now, when she is asked to look straight, she is looking straight, you see, there is some misalignment in the vertical direction, and you see vertically the eyes are not aligned. When you are asking her to look left, she is able to turn the gaze towards the left side. When you are asking her to look to the left, sorry, this is the right and this is the left, here again there is a discrepancy in the alignment. The eyes are not looking properly. When she is asked to look right down, both the eyes are having same axis. When she is asked to look down, both the eyes are looking same. But when she is asked to look to the left, then there is again a misalignment. There is difficulty in this eye to look down. That means in adduction, this eye is not able to do. In the left side, when you are asking her to look down, the left eye is looking down, but the right eye is not able to look down. So there is a problem in the depression in adduction, which is a function of a superior oblique. The superior oblique of the right eye is supplied by left side nucleus. That's what left side fourth nerve. So in this, where is the problem? Is it the left dorsal midbrain, right ventral midbrain, left ventral midbrain, right cavernous sinus, left cavernous? Because all the cranial nerves, when they are reaching to the face, they are traveling to the cavernous sinus and enter the orbit through superior orbital fissure, inferior orbital fissure and the optic canal. So where is this problem? If you look at that, it is left dorsal midbrain. As I said, if you go back to that picture which we have seen earlier, this picture, and see the left dorsal midbrain, is the affliction in this case, because the fourth cranial nerve is supplied from the other side. The right superior oblique palsy, hypertrophy, I mean eye is elevated, and there is a problem in depressing in adduction, and there is a left horner syndrome. Fourth nerve crosses on the dorsum of the midbrain and supplies the right superior oblique. So the peculiarities of fourth cranial nerve are it is dorsally decussating and it is supplying the contralateral superior oblique muscle. And the fourth nerve and sympathetic fibers are closed, hence you get Horner syndrome on one side. So that finishes our midbrain study of the brainstem syndromes. We're going to the pons now. Now you see the pons area on the, this is the midbrain. You have various lesions in the pons. So this is another Pontine infarction, midline pons, and so coma, because reticular activating system is involved, quadriparesis, sensory loss, gauge palsy, locked in syndrome. So there may be artery to artery embolism or there may be branch occlusion in these cases. And as I said, this is a circulation that is supplying the uh, anterior circulation and posterior circulation. The basilar artery usually supplies the Pontine area with short ciliary and long ciliary branches from the basilar artery. So you see here, there is a pure motor stroke, ataxic hemiparesis. So this is the vertebral arteries, the joint form the basilar artery, and you see here there is a narrowing, and this is a supply. This resulted in a stroke here because the compromise of the lumen, and there may be, these are the various manifestations that can come with the Pontine infarcts. So Pontine infarcts can be in a midline or it can be the whole of the pons. So dysarthria clumsy hand syndrome is a Pontine base infarction, the corticospinal tracts and crossing corticobulbar fibers that will cause dysarthria, and this will cause and clumsiness of the hand. Dysarthria clumsy hand syndrome. So you have the corticospinal tract here, the abducens nucleus, and the trigeminal tract, the spinothalamic tract, the aqueduct. So you have to visualize this anatomy in the brainstem. So there are various infarcts which you can see, and in the brainstem syndrome, the Pontine syndromes, and you can see the lateral pons, how the blood supply is coming from the basilar artery, various, and any of them can get blocked and cause infarctions because of atherosclerosis or lipohyalinosis changes. You can have a lot of damage, small areas. Study the four diagrams and identify the structures which are affected in this case. And what are the structures affected here in this first diagram, which is pons and you see, you can see that this is a sixth nerve that is coming, this is a seventh nerve that is going on like this. These are the fibers, motor fibers, pyramidal tracts, right? So what are the if these areas are damaged like this, and like this, unlike this, in what will be the likely symptomatology the patient can come with? So the blood supply which is carrying oxygen and glucose to the brainstem can get interrupted because of various changes, and these are called lipohyalinosis changes, atherosclerotic changes. They can be blocked and predisposed by diabetes and hypertension. So healthy lifestyle is very important. First thing to learn is Millet-Gubler syndrome in pons. This is the area of damage here. The basilar artery perforators, median and paramedian perforators are affected, and it causes ipsilateral seventh nerve palsy. This is the seventh nerve palsy. Ipsilateral abducens nerve palsy. This is the abducens nerve that is coming down, and contralateral hemiparesis, corticospinal tract in basis pontis is affected. So the Millard-Gubler syndrome is a crossed hemiplasia which has got a seventh nerve, a sixth nerve on one side, and hemiparesis on the other side. Foveli syndrome, dorsal pontine segmentum. Here also, this basilar artery perforators and the left side seventh lower motor neuron palsy, nucleus or fascicles can be affected. There will be a gauge palsy, gauge paralysis, because of nucleus of the abducens is involved. This is the nucleus of abducens that is involved, and of course because of this you got contralateral hemiplegia. So you see, we'll see what is gauge paralysis, and you just keep it in mind. I'll show you a wonderful diagram so that you won't forget. Ventral Pontine syndrome. Here, this ventral Pontine syndrome has got only one thing: basilar artery paramedian perforators are involved, and ipsilateral sixth nerve abducens and contralateral hemiparesis. So, sixth nerve and contralateral hemiparesis, ventral Pontine syndrome. Marifoic syndrome. Here, the basilar artery perforators again are involved. Ipsilateral cerebellar ataxia because corticopontocerebellar fibers from this cerebral cortex to the pons. Corticoponto, what we call is corticopontocerebellar or dentatorobothalamo-cortical fibers. That is the circuit. Contralateral hemiparesis because of corticospinal tract and basis pontis. Contralateral impairment of pain and temperature sensations because there is involvement of medial lemniscus also. So this, with this short introduction of the pons, we'll see a case. A 50-year-old diabetic man has a sudden onset of left side face weakness and double vision. On examination, he has left facial weakness involving the forehead elevation, eye closure, and mouth closure. You examine his eye movements and you see. Now you see, there is a finger here which you are able to see before, and you are asking him to look at this place towards the left side. And you are looking at the left side, both the eyes are not able to move. You see, this eye is here, this eye is here, they are not moving at all. He is asking him to look at the left side. If you are asking him to look at the right side, the finger is showing here, he is asking him to look at the right side, this eye is moving, and when his right eye is moving but still the left eye is not moving at all. So out of the possible four movements, there is only one movement that is possible. This is called left gaze palsy. Left gaze palsy. Now what is gaze palsy now understood? This is left gaze palsy. So here you can see that the when he is asked to look at the left, both the eyes are not moving at all. When he is asked to the right, only the right eye is moving, the left eye is not at all moving, and this is called left gaze palsy. The coordinated movements between the two eyes mediated through medial longitudinal fasciculus is affected. Is it because of the right dorsal pons? Is it because of the left dorsal pons? Right ventral pons? Left ventral pons, subarachnoid space. One thing we are sure, because this individual has sudden onset of left face weakness and double vision, there is facial weakness. That means it's a dorsal. You remember where the facial nucleus is. That facial nucleus is on the back side. There is a genu, and you can see that, you can see the facial nucleus which is here, and this is coming like this. This is the abducens nucleus. Okay. So where is the problem in our this case? So now you learned about the gaze palsy here. So most likely localization is left dorsal pons, and you can see the diagram. That's how you get the MRI picture in these cases. And you can have the lower motor neuron type of facial palsy which we discussed, and you can see the facial nucleus and how the this is the abducens nucleus, and these are the corticospinal fibers which are coming down. So this is called facial calculus, and this is called genu of the facial nucleus, and of course there is medial longitudinal fasciculus here. So if all of them are involved in this case, so that's a particular very good anatomy. If only the abducens nucleus is involved, you'll have ipsilateral abducens, that is lateral rectus palsy. If that means either it is fascicle or if the nucleus is involved, so there are two you have to differentiate. Left side, if only abducens nucleus, I'm sorry, for the fasciculus involved, you will have only isolated. But if it is nucleus that is involved, the medial longitudinal fasciculus is also affected. So the gauge is affected. That's what you have seen. The left lateral gauge is completely gone in this case. So because as I said earlier, the movements that are present are only this moment. Out of four possible moments, only half moment is left. So this is called one and half syndrome. This is called one and half syndrome. You can also call it as eight and half because seventh nerve also is involved. So this is possible whenever there is a nuclear lesion of the abducens nucleus at sixth nerve along with medial longitudinal fasciculus. You can call this as one and half syndrome. Remember this one and half syndrome and importance of examination of the eye in midbrain. That's very important. The Pontine syndromes involving the sixth nerve, and you can see all of them are listed: the Raymond's, the Millet Gubler, foveally, and dorsal medial pons. We will not go into the details. We'll go into fifth case, which will again teach us something which is very, very interesting. A 50-year-old diabetic woman presented with diabetic ketoacidosis, and she also has vision loss, and then that vision loss is very important aspect. She has then developed visual loss and double vision both. And on examination, she has left forehead numbness, decreased left eye abduction, and we'll show you some photograph. So just again read this thing. 50-year-old diabetic woman presented in diabetic ketoacidosis develops vision loss and double vision. On examination, she has left forehead numbness, decreased left eye abduction, and I'll show you a picture. There are four cranial nerves in the medulla, four cranial nerves in the pons, and four lumps in the midbrain with third and fourth cranial nerve. Okay, so that rule goes. And now next is the most local localization. Now you see, they are focusing light on this eye. This is the battery, and the pupil constricts here, also constricts here, because as the light is focused, there is a pupillary constriction. Light is being focused on the left eye. This is dilated and this is also dilated. So this is called what is this called? RAPD, the afferent pupillary defect. So that means whenever you see such finding, the optic nerve is under threat. So in this case, where is the problem? Left dorsal pons, left ventral pons, cavernous sinus, superior orbital fissure, and orbital apex. If you remember the 4-4-4 rule, there is no vision or optic nerve in brainstem. This individual has vision loss and double vision. That means the problem is not in the brainstem, it is beyond. Optic nerve is involved here. Now, one thing you learnt is afferent pupillary defect. When they are doing it from the left side, and you see, I'll show you again. In the next picture, you can see clearly. You are focusing a light here, and what happened in the light? When you focus light, there is pupillary constriction here also. From the left side, if you focus, dilatation of the pupil on both sides. That means it is not constricting. The direct light reflex and consensual light reflex both are absent. So it is called afferent pupillary defect. And of course, the left orbital apex is under threat because optic nerve is also involved. You can see the trigeminal dermatomes, that is a V1 distribution, V2 dermatome, and of course V3N. So this will help us in understanding the cavernous sinus anatomy and superior orbital fissure and orbital apex anatomy. Here you see, this is the inferior orbital fissure. This is the superior orbital fissure, and this is the optic nerve here. And you see lateral rectus, inferior rectus, medial rectus, superior oblique, and lid and superior rectus. So these are the various nerves that are traveling. identify the maxillary nerve in the, it's not a part of the superior orbital fissure. Optic nerve is not a part of superior orbital fissure. That means if optic nerve is involved, it is not superior orbital fissure syndrome. And how do we differentiate? And you can see the various nerves that are present in the cavernous sinus. This diagram everybody should know, and there is internal carotid artery in this, and also oculomotor nerve third here. You can see trochlear nerve, ophthalmic artery, that the ophthalmic V1 branch, and maxillary here. Mandibular is not a part of cavernous sinus, it goes to rotundum. So this is an important table because the examination, when you are trying to localize, whenever you encounter third, fourth and sixth nerve palsies, so V1, that is corneal reflex, is absent, then you have to look for what? Is there any sympathetic dysfunction, Horner syndrome, and also cheek numbness, which will give you V2 or maxillary distribution, and whether optic atrophy or vision loss is there. So with the help of optic nerve function and cheek numbness, you will be able to diagnose or localize where is the problem. So I'm trying to tell you that the neuroanatomy of the part is very, very important. So we have covered midbrain, we have covered pons, and come to medulla, and medulla has this corticospinal tract here. This is a medial lemniscus, and you have spinothalamic tract and ascending trigeminal thalamic nucleus ambiguous, descending trigeminal tract, inferior cerebellar peduncle, and posteriorly or dorsally you have the vestibular nuclei. So if you look at that, and this understanding is very, very important, the and grossly you can remember pyramidal tract is here, ascending fifth nerve, nucleus ambiguous, and of course inferior cerebellar peduncle and vestibular nucleus. This is the dorsal aspect. So these are the medial lemnisci, and you can see the spinothalamic tract, arm, trunk and leg, how they are distributed. Now these are the infarcts which you can see in medulla, giving rise to focal disturbances in motor and sensory functions of the body, and various areas can be identified, and ventromedial 32% infarct you can see, and ventral 19%, and you can see the midline, and ventromedial 42%. So depending on the vascular involvement, various anatomical structures which are seen here, that is medial lemniscus, corticospinal tract, hypoglossal nerve, optic nerve, optic nerve, optic nerve, right? So you can have isolated dizziness and vertigo or ataxia as a cause for vascular syndromes here, and these are the anatomy of medial lemniscus, which is midline, spinothalamic tract, inferior cerebellar peduncle, superior portion of the vestibular nuclei, which is dorsally placed, nucleus ambiguous, and the spinal trigeminal tract and nucleus. You can have small infarcts which can cause dysfunction because of the, so most of the brainstem syndromes can be lacunar and small areas of damage. Study the following two diagrams and identify the structures which I have just narrated. What are these structures which you are seeing here? What are these structures which you are seeing here? Sorry. So there is a medial lemniscus here, right? And this is the motor part, that is okay. So these are the things which you have to identify. Wallenberg syndrome, this is the lateral medulla, this is the Wallenberg syndrome, and posterior inferior cerebellar artery territory is this. You got ipsilateral hemiataxia because inferior cerebellar peduncle, which is stationed here, will be affected. There will be dysphagia, hoarseness, ipsilateral palatal weakness because of nucleus ambiguous involvement. The sympathetic thing is also involved, so you get Horner syndrome, and contralaterally you will be having spinal tract of spinal thalamic tract affliction. So decrease pain and temperature in the ipsilateral because of spinal tract and nucleus of the cranial nerve 5 and lateral spinal thalamic tract affliction that will cause the contralateral similar features on the face and portion of the body. So this is Wallenberg syndrome, which one diagram which we have seen. The second one which you're going to see is the Digerin medial medullary syndrome. Here there is motor weakness. There we didn't see any motor weakness, isn't it? In the Wallenberg syndrome, there is no motor weakness, whereas in the Digerin syndrome, you have motor weakness here along with medial longitude. I mean, this is the lemniscal pathway, and it is seen in anterospinal artery, vertebral artery perforators when they are damaged. Then you have contralateral hemiparesis, that is medullary pyramid is involved, contralateral decrease in vibration and proprioception sensation in the limbs because of medial lemniscus involvement, and ipsilateral cranial nerve 12, that is hypoglossal nerve palsy. Let's see, a 50-year-old diabetic man, we have only two more cases, has sudden onset of dysphagia and hoarseness. On examination, he has decreased pinprick sensation on the right side of the face, left arm and leg. She also has right arm and leg ataxia. That means ipsilateral ataxia, contralateral sensory disturbances. And when you examine the eye, there is an elevation or hypertrophy of one eye, and that is the left eye. And when compared, so where is the problem? Is it on the right dorsolateral medulla, left dorsolateral medulla, right ventral medulla, left ventral medial medulla, and subarachnoid space? So you should see it is because of the right side ataxia, it is ipsilateral ataxia and contralateral spinothalamic dysfunction. So this is the lateral medullary syndrome. So this is an important syndrome which for you to learn, and slowly you'll start learning, and we'll not discuss about this because it's too much for you people with the skew deviation will not see. So here there is a elevation of the deviation of the uvula. When you examine the cranial nerves, you have to ask him to open the mouth and see the position of the uvula, whether it is in the central region or it is deviated to one side. Here it is deviated to one side because the levator villi palatini muscle here, this is a muscle which is paralyzed. So the uvula is pulled by this side on the contralateral, so it is deviated to the healthy side. The uvula is deviated to the healthy side whenever there is a palsy of levator villi palatini. And 45-year-old, this is the last case, diabetic man had the sudden onset of dysphagia, right-sided weakness and numbness 3 months ago. On examination, he has a right arm and leg weakness, decreased right arm and leg vibration sensation. When you examine the tongue, you notice that tongue is deviated. So tongue is deviated to the left side. He has got right-sided problems, right arm and leg weakness, and reduced right arm and leg vibration sensation. So where is the problem? Is it on the right dorsolateral medulla, left dorsolateral medulla, right ventral medial medulla, or left ventral medial? So which side is the problem? Is it on the right dorsolateral medulla, left dorsolateral medulla, or left ventral medial medulla? So this is the problem. And most here, and this is the pyramid, this crossed fibers are not yet crossed, they are going to cross. Hypoglossal nucleus is here, and these fibers are also coming here. And this is the tongue. The tongue is supplied by
Sir, something problem is there. We can't hear. Hello? We can't hear, sir.
and both sides genioglossi. Since when you are not hearing? Hello.
Hello, now okay, sir. Yeah, we can
So
hear.
The tongue is supplied by genioglossus muscle, and that is attached to the back side of the tongue. If both the genioglossi contract, the tongue is pushed forward. If one of the muscles is weak, what happens is the tongue is deviated. The tongue is deviated to the you see, this is the deviated to the other side, because the affected side is weak on the back side, so it is not able to push the tongue, but the tongue is deviated towards the tip of the tongue is deviated to the other side, that is the contralateral side. So we have seen midbrain syndromes, Weber's, Benedict's, Claude's, Northangle's, Pontine syndromes, Millet-Gubler and Fovielli syndrome, ventral Pontine, Mary-Foix, Wellenberg and Digerine syndromes. These are the brainstem syndromes which we should remember. Then localization principles, you remember that 4-4-4 rule, and also remember that dorsally you have most of the cranial nuclei, and ventrally you have motor, and some of these motor nuclei, they send their fibers ventrally and they exit ventrally. They have to travel through the brainstem parenchyma, so in the process they can get affected. So in the summary, we have seen a great thing about the third nerve nuclear complex. We also learned about superior orbital fissure, inferior orbital fissure and the orbital apex. We learned about the abducens nerve and the genu of the facial nerve, and we learned a lot about the Weber syndrome, and of course the tongue and this thing. So that finishes class on brainstem. And do you have any questions? And we have, I think, crossed our time. No, just finished. 2 minutes left. So see, this is a difficult portion. We tried sensitizing you to the anatomy of the brainstem. Now I have given you some guidelines about midbrain, pons, and medulla. You try and read today what are the various structures. Importantly, main the action potentials that travel up and down or through the brainstem from cortex to the spinal cord, from spinal cord to the cortex, spinal cord to the cerebellum, cerebellum to the spinal cord, one area in the midbrain to the other, to the pons. So all these areas, and along with that there are stations of cranial nerve nuclei. So whenever there is a damage, you get crossed hemiparesis. Okay, with this I think I'll close here. Thank you very much for the attention, and